Buonasera, everyone. Good afternoon. It's our 14th day of our liver imaging series. Today, it's my pleasure to introduce Dr. Avinash Kambadakone. Avinash.
Yeah.
Avinash will talk about.
Thank you, Khaled.
Can you please advance the slide, Avinash? Yes, thank you very much. So, Dr. Kambadakone is a great colleague and a friend. He is a very nice guy, and he's working at Harvard Medical School. He is associate professor at Harvard Medical School. He is. Can you go back, please?
You can cut it short. We can directly go to my lecture.
You don't want me to introduce you. No, I have to give you at least summary of what you have accomplished. Avinash is the chief of the CT service at MGH, and he's associate professor of radiology at Harvard Medical School. Avinash is the fellow of the Royal College of Radiology, and he's also a fellow of several societies, including Society of Advanced Body Imaging and Abdominal Radiology. He's also on the editorial board for Journal of Computer Assisted Tomography and the associate editor for Abdominal Radiology Journal. He is the chair of the Technique Working Group of LI-RADS and the co-chair for the SAR Disease Focus Panel on the pancreatic ductal adenocarcinoma. Dr. Kambadakone's main areas of interest of clinical interest are imaging evaluation of diseases of hepatobiliary, pancreatic system, and gastrointestinal tract. His research activities are focused on investigating clinical applications of cutting-edge CT innovations in abdominal imaging. Among the advanced CT techniques, his research is focused on exploring the novel CT-based imaging biomarkers such as CT perfusion and CT texture analysis in abdominal malignancies, as well as implementation, optimization of dual energy CT technology in clinical practice. This is just a summary of Dr. Avinash Kambadakone accomplishments. Today we have the pleasure of listening to his lecture, which is going to be about LI-RADS technical recommendations. So Dr. Kambadakone, please.
Hello, everyone, and thank you so much, Khaled, for that kind introduction. I don't know if I deserve all that, but before I start, I would like to, applaud and acknowledge the hard work and efforts of Khaled for his incredible work in getting this webinar started and making it such a great success, and ensuring that the education mission of LI-RADS remains strong. So I want to thank him for all his efforts and also for inviting me to give this lecture. So these are my disclosures. So in this lecture, I will start with the rationale for the LI-RADS technical recommendations, follow it with the detailed discussion on the different technical requirements, including definition and description of the various dynamic imaging phases, and also discuss some of the pitfalls and challenges in optimal image acquisition. Now, imaging plays a critical role in the management of patients with HCC, as you must have witnessed in the prior 13 lectures. And HCC is unique among different malignancies in that it has tumor characteristics on CT and MRI that allow for a highly accurate diagnosis without the need for an invasive biopsy. And if you look at the current ASLD guidelines, which is included LI-RADS, they recommend diagnostic evaluation of HCC with either multiphasic CT or MRI for diagnosis and staging of HCC. If you look at the LI-RADS CT-MR diagnostic table, the hallmark imaging characteristics and the major features, which include arterial phase hyperenhancement, subsequent washout appearance, and capsule appearance, are based solely on enhancement features of HCC against the background hepatic parenchyma. And to enable confident diagnosis and identification of these features, a multiphasic dynamic CT or MR scanning is required. So that was the reason why LI-RADS took the initiative to develop the technical recommendations. Now, if you look at this algorithm for assigning untreated observations in patients with high risk of HCC, among the various categories, the one on top is the LI-RADS NC or LRNC, that is non-categorizable. So this refers to situations when liver observations cannot be categorized due to image degradation or omission. So when you image patients with high risk for HCC, it becomes important that you have enough emphasis on imaging acquisition and technique so that you can categorize the different observations in categories other than LRNC. Uncertainty in diagnosis due to either poor imaging technique or non-standard technique can lead to additional imaging investigations, potential biopsy, and therefore can increase the burden for patient and healthcare. Therefore, optimal imaging technique is crucial. Now, one of the other reasons LI-RADS wanted to recommend technical requirements was the wide variation in imaging technology. Now, if you look at the practice around the world, the image technology landscape is very heterogeneous. There are a number of different scanner and vendor options. Each technology has numerous technical parameters. There are several different types of contrast media available. And in addition, there are various patient factors which can affect the technical quality. So therefore, a technique working group was formed under the auspices of LI-RADS with the goal of developing minimum technical requirements for the performance of CT and MRI to achieve the delicate balance of wide acceptability as well as diagnostically optimal imaging. So I wanted to emphasize on the word minimum because the technical requirements which are proposed by LI-RADS Technique Working Group and the steering committee are minimum technical requirements. Of course, if your institutional experience or expertise allow you to go beyond the technical requirements proposed by LI-RADS, you should be able to do that to allow a confident diagnosis of HCC. Now, these technical requirements are mostly evidence-based, and in those situations where high-grade evidence is not available, it has been based on consensus expert opinion. So now let's go on to look at the different technical recommendations. I'll start with some of the basic technical recommendations for scanner technology and contrast media considerations, followed by a discussion on the different dynamic contrast enhanced phases. So coming to the technical recommendations for CT, let's start with the type of CT scanner which is required for performing a liver imaging. Now, single slide CT scanners, which are characterized by the presence of a single row of detectors, are limited by slower scan speed and long acquisition time. So while you are able to acquire high quality liver images in a single phase using a single row detector CT, such as in the portal venous phase, their ability to do multiple phases is limited. As a result, the accuracy of single detector CT for detecting small HCC is low. Multi-detector CT, which is characterized by the presence of multiple rows of detectors, offers several advantages over single detector CT, including the reduction in gantry rotation time, the ability to acquire multiple thinner sections due to higher Z-axis spatial resolution. Now, what this enables to do is it enables scanning of the entire upper abdomen repeatedly in multiple phases, that is arterial, portal venous, and delayed phase within a series of comfortable breath holds. Faster acquisition also reduces motion artifacts, which is particularly important in patients with ascites due to cirrhosis. And also the thinner submillimeter sections obtained with multi-detector scanners diminishes partial volume averaging artifacts, thereby improving the sensitivity for small lesions. So if you look at the technical requirement for CT by LI-RADS, a multi-detector CT scanner is required for multi-phase exam of the liver. Now let's look at the number of detectors required. Increasing the number of detectors from 4 to 8 to 16 and 64 allows acquisition of thinner sections along the Z-axis, which facilitates generation of isotropic data sets. Now, it has been shown that the tumor detection rates improve significantly with the increase in the rows of detectors. For example, a 8-row multi-detector CT has higher sensitivity and positive predictive value for detection of HCC compared to the 4-row detector CT. Now, there is limited data comparing 8-row CT with higher detector configuration. So LI-RADS, in congruence with OPTN, recommends a multi-detector scanner with 8 or more detector row for optimal liver imaging for allowing confident diagnosis and staging of HCC. Now let's go to the scanner configuration for MRI. Now, there is limited literature on the performance of liver MRI on lower field strength magnets, particularly less than 1 Tesla. Most of the available data on lower field strength magnets has been for non-contrast exams performed without the administration of gadolinium. Generally, if you look at the liver MRI performed on lower field strengths, they have inferior signal to noise ratio and image quality. Higher field strength magnets, that is those over 1.5 Tesla, are preferred for liver imaging because they not only allow reliable scanning of the liver in the arterial and portal venous phase, but they also have higher spatial and contrast resolution, which allows evaluation of small hepatic lesions. Now, the diagnostic accuracy for both 1.5 and 3 Tesla is comparable. Though there is a slightly better improved dynamic contrast enhanced image acquisition with the 3 Tesla scanners. In addition to using higher field strength magnets for liver imaging, a phased array coil is recommended by LI-RADS because it provides better image quality and improved contrast to noise ratio, and also allows faster acquisition time. Now let's go over what are the slice thickness requirements for CT and MRI. Now, if you look at the ACR, SPR practice parameters for CT, they suggest a slice thickness of 5 millimeter or less for CT examination of the abdomen. So in going in with those recommendations, CT scan of the liver with the slice thickness of 5 millimeter or less not only allows depiction of small lesions, but also allows in creation of detailed segmental and vascular anatomy of the liver for treatment planning. Now, multi-detector row scanners allow acquisition of thinner sections. So where possible, thinner section can be obtained because they have higher spatial resolution and less partial volume averaging. But they have higher noise. So it's a delicate balance between higher radiation dose from thin section acquisition versus 5 millimeter acquisition, which allows you to get a low radiation dose and a comparable accuracy. Coming for MRI, if you look at the ACR, SPR practice parameters for MRI of the liver, generally the slice thickness and interslice gap for scans obtained with the 2D technique is the slice thickness is less than or equal to 8 millimeters with the interslice gap of 2 millimeters. But for post-gadolinium enhanced series, image acquisition with the 3D technique is preferred, and the slice thickness can be minimized to achieve high spatial resolution. Typically, OPTN and LI-RADS recommends slice thickness when you do a 3D technique for dynamic MR imaging series to be around 5 millimeter or less. Now, since contrast plays such an important role in performing a dynamic CT or MR of the liver, it is important to have some detail on the type of contrast used. For CT, if you look at the contrast characteristics, the total iodine dose and the rate of delivery of the iodinated contrast agent is very important, not only for opacification of the hepatic artery, but also for the enhancement of liver parenchyma and detection of hypervascular HCC. LI-RADS recommend use of moderate or high iodinated contrast media concentration, that is an iodine concentration of 300 milligram iodine per ml or higher, for improved detection of hypervascular HCC, and also they give you good quality CT images. Now, in patients, those patients with decreased cardiac output, obesity, cirrhosis, or portal vein thrombosis, because these conditions can affect liver perfusion, higher contrast iodine concentration is preferred. Using a higher iodine concentration in these conditions not only improves the liver to lesion contrast, but also provides higher hepatic parenchymal attenuation in the portal venous phase to depict the portal venous phase washout appearance. Now, in MR, LI-RADS recommend both use of either extracellular contrast agents or hepatobiliary contrast agents, depending on the institutional preference. Now, in addition to using the right contrast agent, its accurate timing of the image acquisition during the various dynamic phases is critical to enable precise determination of the liver lesion characteristics and its enhancement. Now, there are two methods which could be used to time the image acquisition with contrast delivery. You could either do a test bolus technique or bolus tracking method. Bolus tracking method is preferred for liver MRI because it allows use of reduced contrast media, reduces the examination time, and also when you use a test bolus technique, there is potential for reduced conspicuity of the hepatic lesion due to the initial dose of contrast agent. Now, of course, while bolus tracking method is desirable for precisely timing the acquisition of various dynamic phases, the technology is not widely available. In such situations, particularly in healthy patients, fixed timing methods can be used. However, in those patients who have large amount of ascites, venous thrombosis, or cardiovascular comorbidities, bolus fixed timing method is a suitable option instead of a bolus tracking method. So LI-RADS recommends both bolus tracking or fixed time delay for accurate timing of the various dynamic phases. Now, let's go over to the different contrast enhanced phases which are useful for characterization of liver lesions and are important to be included in a multiphasic liver CT or MRI. Now, it's important to remember that liver, given its dual vascular supply, where 75% of the blood comes from the portal venous system and 25% of the blood supply comes from the hepatic arterial system, the enhancement pattern of the liver in different phases varies. It results from sequential opacification of the hepatic artery, followed by the portal vein, the enhancement of the hepatic parenchyma, and the hepatic veins after administration of intravenous contrast. Now, the different contrast enhanced phases I will discuss for a optimal liver CT or MR include precontrast imaging, arterial phase, portal venous phase, delayed phase, transitional phase, and the hepatobiliary phase. Precontrast imaging are those images which are acquired before administration of contrast, and these images allow you to determine the intrinsic CT attenuation or T1 intensity of observation compared to the background hepatic parenchyma. They also act as a baseline to determine imaging findings after contrast enhancement. Precontrast imaging is also helpful because it allows additional information on presence and distribution of fat, iron, calcification, or blood products within the lesions. While precontrast CT can contribute to LI-RADS categorization, the incremental benefit in CT is low, and addition of this additional series increases radiation exposure. Because the risk benefit of precontrast CT is not established, LI-RADS suggests but does not mandate the use of an enhanced CT image for initial diagnosis of HCC and staging. However, in those patients who undergo either locoregional systemic therapy, because the treatment zone can often be heterogeneous due to presence of edema, hemorrhage, or necrosis, precontrast CT is required in those patients who have already undergone treatment for HCC. For liver MRI, however, precontrast imaging is required because it facilitates determination of enhancement characteristics, especially those observations which exhibit inherent T1 hyperintensity, when subtraction imaging may be helpful for determination of arterial phase hyperenhancement. Now, coming to the next phase, that is the arterial phase. Now, if you look at the definition, this refers to the post-injection phase in which the hepatic artery and branches, as you can see in this image, are fully enhanced, and the hepatic veins are not yet enhanced by antegrade flow. Now, for all practical purposes, when we say arterial phase, it refers to hepatic arterial phase in LI-RADS. Now, there are two types of two subsections of arterial phase: the early arterial phase and the late arterial phase. What you can see in this image is the early arterial phase, where the portal vein is not enhanced. The late arterial phase is the arterial phase where you do not have opacification of the hepatic veins by the antegrade flow, but the portal vein is enhanced. Now, the importance of knowing the difference between the early and late arterial phase is because the late arterial phase is strongly preferred for HCC diagnosis and staging, because the HCC enhancement is usually greater in the late than in the early arterial phase. In addition, some of the HCCs might show an hyperenhancement only in the late arterial phase. Now, for optimal image acquisition of the late arterial phase on CT, precise scan timing after contrast injection is essential, as I said. So when you're using a bolus tracking method, you could use a scan delay of around 15 to 30 seconds. When you're using an aortic threshold enhancement, so that is when you have an ROI on the aorta, when it reaches a threshold enhancement of 100 to 150 Hounsfield units, you can start scanning after a delay of 15 to 30 seconds to acquire in the late arterial phase. Now, in those situations where you do not have the bolus tracking method, using a fixed time delay of 35 to 45 seconds when you're doing an injection rate of 3 to 5 ml per second allows you to get a good quality late hepatic arterial phase. It's important here to remember, as I alluded to earlier, that the fixed time delay may introduce inaccuracies in patients who have circulatory disturbances. Therefore, it's important that you use the bolus tracking method. Just a note on some of the challenges you can encounter when you're doing arterial phase acquisition in patients who get hepatobiliary contrast agents such as gadoxetate. This phenomenon called transient severe motion has been described in those patients who get gadoxetate. It's seen around 20% of patients. Typically what happens in the arterial phase, as you can see here, there is some motion which limits your ability to look at the liver and characterize lesions. But this transient severe motion resolves in the portal venous phase. Some of the potential risk factors which have been attributed to this transient severe motion include the dose of contrast, BMI, and presence of pulmonary disease. Now, there are some solutions which you could use to mitigate this phenomenon, which include either using a slow injection rate, diluting the contrast with saline, or doing multi-arterial acquisition, or using free breathing sequences. So at MGH, we typically use a combination of multi-arterial acquisition and free breathing sequences to get a good quality arterial phase imaging when we administer gadoxetate. Now going over to the next phase, that's the portal venous phase. Now the portal venous phase is essential for demonstration of hypoenhancement of liver observations. That is for the depiction of washout appearance, which is a LI-RADS major feature. Now this portal venous phase is defined as a post-injection phase in which the portal veins are fully and maximally enhanced. The hepatic veins are enhanced by antegrade flow, and the liver parenchyma is at peak enhancement. So if you see in these images, you see the portal vein is enhanced, the hepatic veins are enhanced, as well as there is increased enhancement of the hepatic parenchyma. Portal venous phase is required both for CT and MRI, both with extracellular and hepatobiliary contrast agents. Now for the timing of acquisition of the portal venous phase, when you're using a bolus tracking method, a delay of around 40 to 55 seconds after a threshold aortic enhancement usually allows you to get an optimal portal venous phase with a good enhancement of the hepatic parenchyma. If you're using a fixed timing delay, which is what we practice at MGH, you typically scan around 65 to 75 seconds after start of injection when you're injecting at a rate of 3 to 5 ml per second. The third phase, the delayed phase, there are some important features here which you need to know. The delayed phase is the post-injection phase, which is acquired after the portal venous phase, in which the portal vein, the hepatic vein, and the liver parenchyma are enhanced, but less than that in the portal venous phase. Now, the delayed phase refers to the phase when you do a multiphasic liver CT or MRI with extracellular agents, or liver MR performed with the gadoxetate, that is contrast agents with modest hepatocellular uptake. It does not apply to MRI acquired with hepatobiliary contrast agents which have strong hepatocellular uptake such as gadoxetate. For such agents, a term called transitional phase is used, which I will discuss in the next slide. Now, delayed phase imaging is important because it improves detection of HCC by allowing depiction of both capsule and washout appearance. Now, there is data to show that delayed phase imaging allows depiction of some HCCs, the washout appearance of some HCCs, which is not seen on the portal venous phase. Therefore, when you use a combination of both portal venous phase and delayed phase, the ability to characterize washout appearance is superior to rather than using just the portal venous phase. Therefore, a delayed phase is considered required both for CT and MRI with multiphasic imaging. Now, for the timing, typically at around 120 seconds after injection of contrast, most of the hypervascular tumors become hypoattenuating to the background liver, and then the liver to tumor contrast remains constant for about 2 to 3 minutes, both for hypervascular and hypovascular HCCs. Therefore, delayed phase can be acquired anytime after 120 seconds, that's 2 minutes after contrast injection, but preferably a delay of 3 to 5 minutes is optimal for getting a good delayed phase. So I alluded to the transitional phase. Now this phase is the post-injection phase, which is acquired after the portal venous phase in patients who get MR with the hepatobiliary contrast agents with strong hepatocellular uptake like gadoxetate, disodium. The reason this is different from a delayed phase is here because there is, as the portal vein and hepatic vein demonstrate decreasing enhancement, because there is hepatocellular uptake of the hepatobiliary contrast agent, there is increasing enhancement of the hepatic parenchyma. So it is important to know this distinction between the transitional phase and the delayed phase when you are using the two contrast agents for MRI. Now, transition phase acquisition with gadoxetate helps provide some of the ancillary features, such as for characterization of focal observations, such as the hepatobiliary phase hypointensity. Therefore, when you perform an MRI with the hepatobiliary contrast agent, such as gadoxetate, transitional phase imaging is required for diagnosis. Coming to the last phase, that is a hepatobiliary phase. Now, this is the injection phase after administration of hepatobiliary contrast agents, in which the hepatic parenchyma is hyperintense to the hepatic blood vessels. As you can see here, you also see some excretion of contrast into the biliary tract. Now, hepatobiliary phase is required for MRI performed with hepatobiliary contrast agents with strong hepatocellular uptake, that is gadoxetate, disodium, because it allows you to diagnose some of the ancillary features. For patients who get hepatobiliary contrast agents like gadominate, which does not have a strong hepatocellular uptake, this is a optional sequence. Now, because gadoxetate has, because 50% of the gadoxetate gets excreted into the biliary system within as early as 5 minutes in patients of normal liver function, hepatobiliary phase imaging can be performed within 15 to 20 minutes after gadoxetate injection. In contrast, with gadominate, only around 2 to 5% of the contrast gets excreted into the biliary system early on. As a result, if you want to capture the hepatobiliary phase with gadominate, it typically should be performed around 60 to 120 minutes. But it's important to remember that in patients who have cirrhosis or severe hepatic dysfunction, hepatobiliary excretion can be diminished from the hepatocytes. Therefore, the timing of the hepatobiliary phase can be difficult. In such patients, hepatobiliary phase imaging with gadoxetate can be performed at around 60 minutes and around 2 to 3 hours with gadominate. One more thing to know, because the liver parenchyma enhances with the hepatobiliary phase contrast agent in this phase, using a higher flip angle improves the T1 contrast. So generally when you do, if you look at the flip angle for dynamic sequences, it's around 10 to 15 degrees. You can increase the flip angle to around 35 to 40 degrees with 1.5 Tesla and 25 to 30 degrees with T Tesla to improve the T1 contrast in this hepatobiliary phase. So that's about the different contrast enhanced phases. Now I'll go over some of the additional technical requirements for performance of CT and MRI. I'll go start with the multiplanar reformations. Now, performing a liver CT with multi-detector row allows acquisition of thinner sections along the z-axis, so you get the isotropic data set. Now, this isotropic data set enables creation of multiplanar reformations in the coronal or sagittal plane. It has been shown that using a combination of axial and coronal and sagittal reformations increases the reader confidence for evaluation of HCC. They also enable confident diagnosis of small subcentimeter hepatic cysts, which are not easily seen on axial images. So also one area where multiplanar reformations are quite helpful in CT is particularly, as you see in this example, where you see a hypervascular lesion on the axial images, but when you correlate with the coronal and sagittal images, you can see that it has a wedge-shaped appearance extending into the periphery of the hepatic parenchyma, indicating that this is likely a perfusional abnormality. So multiplanar reformations can be helpful to differentiate benign entities like arterioportal shunts and perfusion abnormalities from HCCs, which are more nodular or rounded. So because acquisition of good quality multiplanar reformations may not be widespread, so these are suggested for multiphasic liver imaging. And when you do perform a multiplanar coronal and sagittal reformated images, it is preferable to get around 3 millimeter or less thinner sections so that it complements the 5 millimeter axial images. Now coming over to MR, some of the additional sequences which are helpful for accurate diagnosis of HCC. One of them is T2 weighted imaging. Now, if you look at the definition, it's basically a pulse sequence which depicts the differences in the T2 relaxation times of various tissues. Now, T2 weighted imaging is very important component of any liver MRI series because it provides information about the presence of fluid, fibrosis, or ferromagnetic substances. It allows distinction between solid and non-solid lesions and is also necessary for assessment of a number of ancillary LI-RADS features. So T2 weighted imaging is a required sequence for liver imaging on MRI. Typically, either these could be performed with or without fat suppression. You could do either axial or coronal T2 weighted imaging. They can be acquired either by breath hold or free breathing techniques. Another MRI sequence which is a requirement for liver MRI is the out of phase and in phase imaging, which is also called the chemical shift imaging. Basically, what this imaging technique does is it takes advantage of the differences in the precession frequencies of fat and water protons to generate two sets of images. Now, these images allowed a depiction of microscopic fat within lesions. Now, because this is required for assessments above the LI-RADS ancillary features, they are a required sequence. Now, it is important that when in-phase and out-of-phase imaging is performed, this should be acquired as a dual echo sequence rather than a separate single echo acquisition to ensure that there is good co-registration among the echoes. Also, when you're doing a dual echo sequence, the out-of-phase images should be acquired before the in-phase images rather than the in-phase out-of-phase design. The reason for this is when you acquire the in-phase images first, the signal loss seen on the later acquired out-of-phase images could be due to chemical shift artifact or T2 decay. But if you acquire the out-of-phase images first, the signal loss which you see on the out-of-phase images can be determined to be due to chemical shift artifacts suggesting fat content. And in this situation, when the signal loss occurs on the in-phase images, it could be either due to T2 decay or it could suggest presence of iron content. Now, diffusion weighted imaging is sequence which has image contrast based on the Brownian motion of water molecules, measures the tissue diffusivity, and has become now a routine technique for any liver or any other abdominal MRI series. Now, diffusion weighted images improves the detection and characterization of focal observations within the liver, particularly permitting differentiation of cysts from solid masses. Now, combining diffusion weighted images with the multiphasic MRI, either with the extracellular contrast agent or a hepatobiliary contrast agent, has been reported to improve the detection of HCC, particularly tumors which are less than 2 centimeters. But one of the limitations of the role of diffusion weighted imaging in HCC is that not all HCCs demonstrate restricted diffusion, and the background microarchitecture of the cirrhotic liver shows restricted diffusivity due to presence of fibrotic tissue, which can sometimes influence the conspicuity of HCC on diffusion weighted images. So when a focal lesion having features of HCC shows restricted diffusion, while it can be helpful for diagnosis, absence of restricted diffusion does not help you in such circumstances. Therefore, diffusion weighted imaging is suggested for liver imaging rather than a required sequence. Another imaging series which is quite useful for particularly both for CT and MRI is the subtraction images. Now, the subtraction images refers to post-processed images which are generated from subtraction of the pre-contrast from the dynamic contrast enhanced images. Now, if you look at this series of images here in the pre-contrast, arterial phase, portal venous phase, and delayed phase, lesions which are intrinsically T1 hyperintense, as you can see here, due to either deposition of fat, hemorrhage, or high quantities of proteins, can sometimes make it difficult to appreciate enhancement on the subsequent phases. So using subtraction images, as you can see here, I'm sorry, I think the animation is not working, but these are actually the subtraction images which have subtracted the contrast enhanced series from the pre-contrast images, and that allows you to look for enhancement within lesions. Because the ability to obtain good quality subtraction images is not available widespread, so this is a suggested sequence rather than a required sequence for a liver MRI. So those are the different sequences and the contrast enhanced phases for the different CT and MRI of the liver. Now I'll briefly go over what are the, on a broader section, what are the different technical recommendations. So if you look at the summarize the CT technical recommendations, you need a multi-detector row scanner with a minimum of 8 detector rows. The axial slice thickness for CT is less than or equal to 5 millimeters. Multiplanar reformations are suggested with the section thickness of less than 3 millimeters. Pre-contrast imaging is suggested and not mandatory for initial diagnosis, but is required for those patients who have undergone locoregional therapy. Now, the 3 dynamic contrast enhanced phases which are required for a multiphasic CT include the arterial phase, portal venous phase, and delayed phase. Late hepatic arterial phase being strongly preferred over early arterial phase. For contrast timing, bolus tracking or fixed delay is suggested with the higher concentration of iodinated contrast agent. Typically, an injection rate of over 3 ml per second should be used. And it's important to know that whenever you're using power injectors, it is important to follow the contrast bolus with a saline chaser with the same injection rate, because it reduces the amount of contrast agent, pushes the contrast bolus into the central system, thereby improving the utilization of the contrast used. So these are the typical contrast enhanced phases on CT. You have a pre-contrast imaging, which is optional for initial diagnosis. You have the late arterial phase, portal venous phase, and delayed phase, all of which are required for accurate diagnosis of HCC. This is the summary of the technical recommendations for extracellular agents, MRI, and MRI with the hepatobiliary contrast agents such as gadobinate, which does not have a strong hepatocellular uptake. So the equipment, you need a high field magnet strength of 1.5 Tesla or over. Phased array torso coils are required. Among the required images for an MRI include T2 weighted images, T1 weighted chemical shift images, that is out of phase and in phase images. For the multiphasic T1 imaging after administration of contrast, you need the arterial phase, portal venous phase, and delayed phase. Some of the suggested images include the diffusion weighted imaging, subtraction imaging, multiplanar acquisition, and for gadobenate, 1 to 3 hepatobiliary phase is optional. So these are the images for different images acquired for with extracellular agents. You have the pre, late arterial, portal venous, and delayed phase, the in-phase and out-of-phase images, and the T2 weighted images. These are the different images obtained with the MR for gadobenate. You can see the pre images, arterial, portal venous phase, and delayed images, and the hepatobiliary phase images obtained around 1 to 3 hours after injection of contrast are optional. With gadoxetate, which has a strong hepatocellular uptake, that's why you have the transitional phase where you have increase in the enhancement of the hepatic parenchyma. Most of the requirements are similar to MR with extracellular agents. What is different here is that instead of the delayed phase, the terminology here is the transitional phase, and the timing is similar, that is 2 to 5 minutes after injection. And the hepatobiliary phase for gadoxetate is required rather than being optional. So these are the different images acquired after gadoxetate injection. You can see that the hepatobiliary phase here is required, so rather than being optional. Now, if you compare the technical requirements for OPTN versus LI-RADS, you can see that for the technical requirements for LI-RADS are concordant with that of the OPTN, while OPTN does not have recommendations for pre-contrast imaging and multiplanar reformations. LI-RADS provides those recommendations. For liver MRI, again, you can see the difference between OPTN and LI-RADS. They are mostly congruent, while OPTN does not provide recommendations for diffusion weighted imaging, multiplanar reformation, and subtraction images. Those are available with LI-RADS. Now, just going over the comparative diagnostic performance of CT and MRI for diagnosis of HCC. If you look at the diagnostic performance for diagnosis of HCC, CT while has lower sensitivity compared to MRI for diagnosis of HCC, it has almost comparable specificity. You can also see the numbers is compared to AFP and use of ultrasound. If you look at per lesion sensitivity for diagnosis of nodular HCC, you can see that MR performs better than CT for nodular HCC of all sizes. While they are comparable for HCC over 2 centimeters, for lesions which are less than a centimeter, MR has slight edge compared to CT. Now, I just want to go over one study which compared the CT and MRI for diagnosis of HCC. This was a meta-analysis which was published, which looked at 33 studies, both using a combination of CT, extracellular contrast agents, or gadoxetate. And they compared the accuracy of CT and MRI for diagnosis of HCC. MR had higher sensitivity and lower negative likelihood ratio compared to CT. The accuracy of MRI for detection of HCC was around 90% compared to 80% for CT, and also MR showed higher per lesion sensitivity for HCCs less than a centimeter and over 2 centimeters, but not for HCCs which were between 1 to 2 centimeter. Based on this, the recommendations were that either CT, extracellular contrast enhanced MR, or gadoxetate MR can be used for diagnosis of HCC in patients with cirrhosis. There is no preference of one over the other. It has to be based on institutional preference as well as some of the patient factors. Some of the things which can help you make a decision on using the different imaging technologies is in patients who have ascites, claustrophobia, pacemakers, or hardware, where MRI might be limited by artifacts. CT might be a better option. In patients who are not able to hold their breath, particularly those with ascites and cirrhosis, CT is a better option. In those patients who have liver decompensation or severe iron overload, both CT or MRI can be used. And those patients who have contrast agent contraindications, non-contrast MRI should be preferred. At MGH, most of our liver imaging for screening and diagnosis of HCC is performed with the MRI, and CT is performed in those patients who cannot get a liver MR. So to conclude, multiphasic liver CT and MR is required for diagnosis and staging of HCC. It is important to adhere to the technical recommendations to potentially reduce NC or non-categorizable categorization. CT and MRI have comparable diagnostic capabilities in diagnosis of HCC, though I think MR actually has a slightly higher edge due to higher contrast resolution. It is important to optimize the imaging modality and technical parameters to patient factors and institutional preference to obtain high quality liver CT and MR. With that, I would like to conclude, and I would like to thank my technique working group who have contributed a lot to the development of these technical requirements, and also to our fearless leaders Claude and Victoria for their support. So thank you for your kind attention, and I'm happy to answer any questions.